Chapter 25, Myelodysplastic Syndromes. MDSs are a group of acquired clonal hematological disorders which are characterized by progressive cytopenia in the peripheral blood that reflect defects in the red cell, myeloid, and/or platelet maturation. These conditions are becoming more common finding in the hematology lab, and getting familiar with these disorders is really an essential part of the body of knowledge that all CLSs must know. MDSs may arise as a primary or a result of a secondary or therapy-typed MDS. They are a group of heterogeneous diseases and are a proliferation of abnormal stem cells. The abnormal stem cell may be the result of cumulative effects of environmental exposure in susceptible individuals. They can be caused by chemicals, radiation, or viruses. There has also been a link with smoking. The mutated stem cell produces a pathological clone of cells that expand in size at the expense of normal cell production. Because each mutation produces a unique clone with a specific cellular defect, MDSs have a multitude of expressions. What's common to all MDSs is they have a progressive cytopenia in one of the cell lines at least, despite their cellular bone marrow, and dyspoesis in one or more of the cell lines. The median age for this is 60 and above. It can affect people of all ages, but it's very rare. Proliferation of these stem cells that have acquired a defect prevent them from differentiating, maturing normally. Some differentiate into mature cells, but you can see that there is some kind of ineffective hematopoiesis observed by seeing abnormal morphology, which leads to compromised function. And overall, you're going to see a decrease in the normal number of cells peripherally. This is really a multi-step pathogenesis, which can result from the interaction of the stem cell and its bone marrow microenvironment. Now, really, there has been thought of three causes: either a single gene mutation. Over 50% of these patients have some kind of chromosome abnormality, and the most common chromosomes affected are 5, 7, 8, and chromosome Y, in addition to its proto-oncogene counterparts of JAK2, RAS, or RUNX that have been seen. The instability of this genetic issue of the stem cells contribute to the development of MDS over time. There can even be gene silencing or epigenetic changes that lead to this instability. And overall, this can also result into an acute type of leukemia. Now, the laboratory findings are what help clinically diagnose these conditions. So in the peripheral blood, you will see a cytopenia of at least one cell line with dysplasia in at least one of the cell lines. What gets patients through the door, again, is an anemia and seeing hemoglobins less than 10 grams per deciliter. In addition, patients may have recurring bacterial infections because their absolute neutrophil counts are less than 1.8 times 10 to the 9 per liter. Platelets are also going to be decreased, less than 100 times 10 to the 9 per liter, and they can present with increased bleeding. As anemia is the most common finding, another very common finding in MDS is they are refractory to treatment, meaning that because of their anemia, the causes of getting blood products will not help them. and they might see bicytopenia, so that means 2 of the cell lines being decreased in 30% of the cases, and pancytopenia, so all 3 cell lines being decreased in 15% of the cases. The more dysplasia and cytopenia you have in more cell lines, the worse the prognosis. In each of the MDS categories, you will see dysplasia or morphological dysplastic features in 1 or more of the cell lines. So first we're going to talk about the erythroid lineage. In the peripheral blood, so those are images D, E, and F, the most common morphological finding is the presence of oval macrocytes. So when these cells are seen with a normal vitamin B12 and folate, MDS should be a thought as a differential diagnosis. If there are hypochromic microcytes in the presence of adequate iron stores, this is also a differential diagnosis to help lead you to MDS. A dimorphic red cell population is another indication of this clonal disease, and you can see a variation of abnormalities like poikilocytosis, basophilic stippling, Howell-Jolly bodies, siderocytes, which are all indications that the erythrocyte has undergone abnormal development. Now, in the bone marrow, this evidence is seen with the red cell precursors. So the bone marrow images are images A, B, and C with more than 1 nucleus or abnormal nuclear shapes. The normally round nucleus may have lobes or buds, and they can even nuclear fragment, which can be seen in the cytoplasm in case of a hyperplasia. With the granulocytic lineage, dysmyelopoiesis can be present in the peripheral blood as seen with cells with abnormal granulation of the cytoplasm and neutrophils in the form of larger than normal granules or hypogranulation, which means the absence of granules. Agranular bands can also be easily misidentified as monocytes. And abnormal nuclear features can be seen as hyposegmentation, hypersegmentation, or nuclear rings, as seen in G, H, and I. Now there's no bone marrow images here, but it can be represented in the bone marrow by nuclear cytoplasm asynchrony, meaning cytoplasmic changes include uneven staining or a dense ring of basophilia around the periphery with a clear unstained area around the nucleus, with the remainder of the cytoplasm staining normally. Platelets can also exhibit dyspoietic morphology in the peripheral blood, and the common changes here include giant platelets and abnormal platelet granulation, either hypogranulation or agranulation. Some platelets may even possess large fused granules, and any circulating micromegakaryocytes may be present in the peripheral blood from patients with MDS. So here is a patient with MDS where you can see a normal small lymphocyte and very large macrocytic cells in the peripheral blood. Now here is an example of a patient with MDS showing hyposegmented or pseudo-like Pelger-Huey nuclei. And here's an example of a patient with MDS having a large agranular platelet in the peripheral blood, which is almost the size of that lymphocyte located below. Now here are images of a bone marrow smear. It's a little bit grainier due to the spicules within the bone marrow blood, but you can see the arrow of a multinucleated erythroblast of a patient with MDS, which is also megaloblastoid. It's very large in comparison to the other maturing cells. This is a bone marrow from an MDS patient, and look at the arrows here where you have metamyelocytes with a lack of any secondary granules, and they're still very basophilic in its cytoplasm. And look at the abnormal megakaryocyte from a bone marrow with a patient with MDS, and also the micromegakaryocytes and the features of these surrounding the cells within the bone marrow. So with MDS, you can see a lot of blasts or precursor cells coming out, and it's a most important prognostic indicator because it deals with survival. So the higher the blast count, the worse the prognosis and the conversion to an acute leukemia. So a diagnosis of MDS, it has to have the above characteristics that I mentioned before, in addition to less than 19% blasts. The World Health Organization classifies an acute leukemia with a number of 20% blasts or more. Correctly identifying blasts and the type and degree of dysplasia is important in MDS because these characteristics are the basis of classifying the subtypes within this umbrella of conditions. So there was an internationally working group for morphology when talking about MDSs that developed criteria that redefined the myeloblast morphology. So in addition to refining it, it proposed criteria necessary to define normal and dysplastic promyelocytes and ring sideroblasts. So they have established granular myeloblasts, agranular myeloblast, normal promyeloblast with dysplastic myeloblasts. So here on the left, you have an agranular blast. It has a high nucleus to cytoplasm ratio. The nuclei are fine and chromatin is open with some basophilic cytoplasm. Now the granular blast is present and shows the same morphological characteristics. However, there is cytoplasm granules present. Now with the promyelocyte, you want to start seeing a central or eccentric nucleus with nucleoli and a clear visible Golgi zone with those specific granules being present with a basophilic cytoplasm. Now with a dysplastic promyelocyte, you're having irregular cytoplasmic basophilia, poorly developed Golgi zone, and hyper or hypogranularity with an uneven distribution of those granules. They can even clump together. So here is an example of an agranular blast on the left with a granular blast on the right, and you're seeing those large nucleoli, but they're granules in the cytoplasm of this myelodysplastic blast. So now we're going to talk about the classification of MDSs. In 2008, the World Health Organization performed a classification system and took over the old FAB system and classified them into 6 different groups: refractory cytopenia with lineage dysplasia, refractory anemia with ringed sideroblasts, refractory cytopenia with multilineage dysplasia, refractory anemia with excess blasts, an MDS associated with an isolated deletion of 5q chromosome, or an unclassifiable MDS. It just doesn't fit into the classifications above. So the first classification is refractory cytopenia with unilineage dysplasia. So these patients present with symptoms that are related to cytopenia, namely fatigue or shortness of breath if there's an anemia present. You're going to see increased infections from neutropenia and easy bruising or bleeding if there's a thrombocytopenia present. So this category includes MDS cases with less than 1% blasts in the peripheral blood and less than 5% blasts in the bone marrow. Dysplasia must be present in more than 10% of only one single myeloid lineage. Included in our CUD is a refractive anemia with only dyspoesis. If it's dyspoesis, it must have less than 15% ring sideroblasts, refractory neutropenia, and a refractory thrombocytopenia. Now, although there may be cytogenetic abnormalities seen in up to 50% of these cases of refractory anemia, none are really specific to make a diagnosis. The median survival for these patients is about 2 to 5 years, with only a very low risk of transformation to an acute leukemia. So out of the MDSs, this is the best prognostic type of condition. Classification is refractory anemia with ringed sideroblasts. In RARS, anemia and dyserythropoiesis are present, and there's more than 15% of the bone marrow with erythroid precursors and ringed sideroblasts. So this is an image of a bone marrow specimen with a Prussian blue stain, and you can see the deposits of iron or deposited around the nucleus of these cells. Those are considered ringed sideroblasts. And it must contain at least 5 iron granules per cell, and these iron-containing mitochondria must circle at least a third of the nucleus of the red cell. So in the peripheral blood, there may be a dimorphic picture with a population of hypochromic cells, along with a majority of normochromic cells. This condition occurs primarily in older population with a mean survival of about 100 months. Refractory anemia with ringed sideroblasts and marked thrombocytosis will have a JAK2 mutation that has been discussed with the previous chapter. Next classification is refractory cytopenia with multilineage dysplasia. This is categorized by one or more cytopenia and dysplasia in 2 or more of the myeloid cell lines. It's going to present with less than 1% blasts in the peripheral blood and less than 5% blasts in the bone marrow. Now, some of these cases you can see up to 15% ring sideroblasts. What the difference is, the dyspoesis in more than the erythroid lines places them into this category. The distinction is very important because this type of refractory cytopenia is more aggressive than only the refractory anemia with ringed sideroblasts. So this is a bone marrow picture. It's hypercellular, and you can see that multiple cell lines are affected here. So we are going in order of progression as to worse in this classification. The next classification is refractory anemia with excess blast. This presents with a tri-lineage cytopenia as well as significant dysmyelopoiesis, dysmegakaryopoiesis, or both. According to the WHO classification, the peripheral blood must contain only 2 to 19 blasts. In the bone marrow, blast numbers range from 5 to 19%. This can be distinguished from refractory cytopenia of multilineage dysplasia by the myeloblast percentage, because there are significant differences in survival and because evolution to AML may occur in this scenario. So now the WHO has classified this category into 2 groups, depending on the percentage of their blasts seen in the bone marrow. So for group 1, or RAEB1, you see 5 to 9% blasts in the bone marrow, or 2 to 4% blasts in the peripheral blood. Now in this category, those blasts don't have our rods. This is a fused type of particle seen in the cytoplasm of these blasts. And 25% of these cases progress to an acute type of myeloid leukemia. For type 2, you're seeing 10 to 19% blasts in the bone marrow and 5 to 19% blasts in the peripheral blood. The presence of our rods, regardless of the blast count, qualifies a case into the classification of RAEB2. So with greater than 10% of the myeloblasts having an aggressive course, you see the greater percentage of these cases progressing to AML, so almost 50%. Now this next category, MDS associated with a single isolated deletion in the 5q chromosome, they represent a fairly well-defined syndrome that affects predominantly women and occurring at the age of around 67. These patients typically have a refractory anemia without any other cytopenia or thrombocytosis, any kind of hypolobulated megakaryocytes, or any kind of erythroid hypoplasia. There are less than 1% blasts in the peripheral blood and no our rods seen in those blasts. Patients here have a long-term stable disease with a median survival about 145 months. There's a drug that has been proven to be effective in patients with this condition, in addition to any other isolated gene problem. Of an unclassifiable nature is really a category that refers to any subtype that initially lacked the specific changes necessary to classify them into one of those categories that we discussed earlier. So that includes an RCUD or an RCMB clinical presentation with 1% myeloblasts in the peripheral blood, or an MDS with a pancytopenia and dysplasia with limited to one cell line. Now, patients with no increase in blasts or persistent cytopenias with 10% dysplastic cells in any lineage, but with chromosomal abnormalities, is a consistent diagnosis within the classifications of MDSs. As for prognosis, the median survival for these types of MDSs is usually less than 2 years. Some patients do survive many years, but they have continuous therapy. And the mortality rate is well over 50%, and some can even transform into an acute type of myeloid leukemia, depending on the classification. Now, as for therapy, it definitely depends on the patient's risk, transfusion needs, and the number of blasts, as well as if there's any kind of cytogenetic abnormality identified. There are certain types of FDA drugs that have been approved, but the only curative treatment or potential curative treatment here is a bone marrow transplant. But again, the older the patient, the more likelihood they're not going to put the patient's risk at hand. To those, you can have a combination of an MDS and an MPN category. Now, these include myeloid neoplasms with clinical lab morphological features that are characteristics of both MDS and MPN. So included in this classification are chronic myelomonoleukemia, atypical chronic myeloid leukemia, juvenile myelomono, and MDS MPN unclassifiable. Now, with a provision subtype of refractory anemia with ring sideroblast and thrombocytosis.